I'm here with Dr. Kevin Cavanaugh, a member of Infection Control Today's editorial advisory board. And last year, when people were saying, healthcare experts were saying, and everybody in the media were saying that this virus probably wouldn't mutate, Dr. Cavanaugh was one of the lone experts who said that he didn't see enough data to make a determination about that. In fact, I'll let you tell it, Dr. Cavanaugh. What did you say last year before anybody else said it?
Well, it was quite obvious that this was an RNA virus and it was mutating. Even the initial strain, which we had in the United States, quickly mutated into a more infectious strain, which was the D614G strain. And although the narrative at that time was it wasn't really more infectious, now people are saying that, yes, it was more infectious, and that was a significant mutation. And if you looked at the website called nextstrain.org, you can see all of the mutations that the virus was undergoing, and they track those over time and over distance. Now, the vast majority, or almost all of these mutations, are inconsequential. The mutation has to involve the spike protein area to have a maximum effect on the vaccines or our immunity. But those certainly could occur during that time. And as the virus spread within our population and throughout the world, more and more people became a laboratory for causing viral mutations to occur. And finally, and unfortunately, we've had now a number of mutations. First, the UK strain, which is the B117, which is more infectious and may be slightly more lethal than our current strain. But even more worrisome is a set of mutations which have occurred in Brazil, in South Africa, also has been noticed in the United Kingdom, and also in a patient up in Boston, Massachusetts, all having similar mutations and escape mechanisms which may make these vaccines less effective.
When you say less effective, what do you mean more or less?
Well, you have to realize that the vaccine is targeted to making antibodies to the spike protein of the virus. And that's the same region that our body makes its immunity to, our effective antibodies that kill the virus. And the spike protein is also the key to our antigen and our PCR testing. So if the virus mutates in such a way that that spike protein is changed, then that can affect the vaccine's ability to kill that virus, along with affecting our ability to detect it. You may have false negatives now coming about from some of these variants, and we will not know that the patient actually has COVID-19 by a laboratory test, because the new laboratory tests, which will be adapted to that virus, similar to the vaccines, I'm sure are under development, but they're not out yet. So when a vaccine is to the original virus, it makes a whole plethora of antibodies, all sorts of different types. And the majority of those will not be able to effectively kill this new variant, but some will. So for example, with the Moderna vaccine, it is felt that it will lose probably 5/6 of its effectiveness. In other words, it will fall 6-fold in effectiveness, which is a lot. But those vaccines are so highly efficacious that they feel that it will still give patients protection. And so that's important. And it will especially give you protection for severe disease, such as would require hospitalization or ventilation and death. And so that is a big plus. But it does not look like either the Pfizer and BioNTech or the Moderna vaccines will give protection that will prevent mild to moderate diseases. Now, AstraZeneca and Oxford, because of these new, more severe mutations, have put their vaccine on hold. I assume they're retooling. And Pfizer, BioNTech, and Moderna are making a booster now. So when I look back and thinking what it would take to get out of this pandemic, at one point it was getting one shot to get a vaccine. Then in order for the vaccines to be effective, you needed two shots. Now it looks like the majority of people are going to get two shots plus a booster. And the biggest worry is this virus mutating faster than what you can make vaccines and boosters to? And of course, that's on a lot of people's minds. And I would like to give a little bit of encouragement in that all of these latest escape mechanisms, in other words, from Brazil, South Africa, from the UK, and we're not talking about the UK variant in the United States, but this is now a further mutation of that variant that's only found in Great Britain, and also has been detected in a patient in Boston, Massachusetts. All of these variants have a similar type of mutation. And because these mutations occur randomly and they're all a similar escape key, maybe this is the last type of mutation that virus can easily do to avoid the vaccines. So it may have plateaued in its mutation rate. And I really do hope that this will be a plateau in the mutations. And it also means that it may be possible to get a single booster that will effectively give you immunity to all of these different variants. And so that's on the good news. The bad news is that you're going to, in my case, have to have 3 shots. And I don't like shots. So
says the doctor.
Yeah, I don't like them. My grandkids don't like them. They didn't like the idea of getting 1 vaccination. Now, if they have to get 3, they will not like that at all.
Well, this has actually given me some uplift because you've been such a clear-eyed realist throughout this pandemic. You've been calling things before the CDC or World Health Organization months before they called things. You spotted problems, but now you're spotting a ray of sunshine. You're saying that we can get out of this pandemic because the mutations so far that you've seen and that everybody's seen can be handled by the vaccines, at least to some extent.
Well, and that's correct, but we do need to encourage people to get vaccinated. One of the problems is that about 1/3 of the healthcare workers don't want to get vaccinated. In Kentucky, we had a report that over 50% of the nursing home workers did not want to get vaccinated. And at this point, that probably isn't a good decision. You cannot mandate vaccinations at this point because it hasn't undergone a formal FDA approval process. It just has an emergency use or EUA authorization. But data is coming in, and the longer and longer we go, the more and more data we have, and these vaccines appear to be very safe. So several months ago, when we only had two months of data, you were a little bit more hesitant giving that type of advisement, as we are now when you have 5 or 6 months worth of data. So certainly at this point, people should be getting a vaccine. And here's the thing, Frank. Throughout the history of evolution, and even through the history of mankind, you've seen species get wiped out. You've seen civilizations of man fall because of infections. And the thing that differentiates us from a tadpole is our science and our knowledge. And if we don't take advantage of that, then as a species or a society, we're going to be in the same situation as a tadpole when these infectious diseases are raging. And so we need to follow public health advice, and we also need to get vaccinated. Both of these are needed because they're all layers of armor, and none of them will be 100% effective.
Now, you don't practice, you're retired now, but you practiced medicine for how many years?
Oh, almost 30 years.
So it blows my mind a little bit that the healthcare professionals are hesitant to get vaccinated. Now, you know the healthcare world. You're a practicing physician for almost 30 years. You had some ties, I bet, to hospitals, and I know that you lecture and you talk about medicine. So does it shock you that healthcare professionals are not standing in line to get vaccinated, or?
Well, it really does. And in some places that is the case, especially in some of the smaller rural areas. But you have to remember this pandemic, along with science, has been both discredited and very much politicized in social media and in certain circles, whereby people are almost brainwashed when it comes to trying to talk to them about this pandemic or about the vaccines. Another big fallacy is that they feel that this vaccine was rushed to market, that it was developed in under a year. Well, that's not the case. They've been working on this vaccine for a coronavirus for almost a decade now. We had MERS, we had SARS, this was a known risk. And of course, that led to conspiracy theories that this was made in this lab or purposefully released because people were doing research. But they were doing the research because it was evident and predicted that this coronavirus would be one of the most likely candidates to cause a very severe pandemic. And so because of that, you had vaccines that were already made, such as those of Moderna and Pfizer-BioNTech, that they already had the types of technologies and machines ready to go to make vaccines to particular coronaviruses. And when this coronavirus came along, they received the genetic sequence of the spike protein, they could put it into their machine and essentially print out a vaccine. These vaccines by these initial companies are totally man-made. And that has a big advantage on speed. The disadvantage is, of course, they're not all that stable and have to be stored ultra cold storage. And that makes them problematic on getting them out to the masses. But it does get you a vaccine out there quite quickly to these type of variants. So it's almost like the flu. We get a flu shot every year and no one says, I'm not going to get this flu shot because they've only been developing it for a year. No, they've come out with it every year. And with the companies working on vaccines for coronaviruses, it's the same thing. They just switched the type of coronavirus they were making it for. And that will be the same thing for the booster. They'll get that out quite quickly. But nevertheless, quite quickly means a couple of months, and revaccinating the entire United States is not an easy task. So wearing masks is of utmost importance, as is social distancing and obeying public health advice. This is quite, I just can't stress that more, Frank.
As we talk at the moment, the latest figures I've seen seems to suggest that the holiday surge is at last subsiding, hospitalizations are going down. Do you see the possibility of another surge? And I guess you do if we don't vaccinate faster than these new variants spread, right?
Well, that's correct, because if the UK variant is actually more infectious and more lethal, and we do not have a large portion of our population vaccinated, we could get another surge, especially with the pictures I've seen on the Super Bowl spreader events. It can be quite distressing. I mean, the surge that we went through was from was from Christmas and New Year's. And we may get this again because of the Super Bowl parties, which involved shouting, alcohol, eating, and people intermingling in bars, restaurants, and even with home parties. So we're at risk for another surge. And unfortunately, the Brazilian and South African variants, along with the new variant in the UK, those viruses, they can cause reinfections because they evade the body's immunity. And we may not even know they're spreading because they may also possibly cause false negatives on your tests. In the United States, we do not have good genomic testing. They're just starting to gear that up. That should have been geared up over a year ago so we could test for these variants. You want to test at least 5 to 10% of all positive cases. So you can test for different strains and how this virus mutates. So right now we're kind of flying blind. So if the Brazilian and South African variant, we've had a few cases in the United States, and if it is spreading, that can be very problematic because we cannot detect right now with any degree of accuracy how fast those variants are spreading. Hopefully they won't be. That the UK variant, if it spreads very fast and people are following public health advice, maybe those other variants won't spread as much. But they certainly can be problematic, and they'll cause reinfections. That's been reported out of Brazil, out of South Africa, and that is of utmost concern right now.
We always circle back to what infection preventionists should do in this situation. And you've always said basically they should educate, educate, educate. And I imagine you're saying they should educate their fellow healthcare professionals at the moment, right? That's
well, yes, because right now it's hard to educate the public when they'll say, but a third of the people at your hospital isn't getting vaccinated. Yeah, you need to get the hospital workers vaccinated first. I think there's no question about that. And they not only need to be offered the vaccine, but they should be setting an example for the community. Because regardless of the risks of this virus, or I'm sorry, regardless of the risks of the vaccine, the risk of the virus is so much, many-fold higher than what the vaccines are. I mean, we have given out tens of millions of doses at this point in the United States, and there are maybe 1 or 2 possible cases which are related in time as far as having a fatality that is associated with the vaccine. And when you talk about 1 or 2 cases out of tens of millions of vaccinations, that's an extremely low number, so low that they might have occurred anyways. In other words, it may be totally unrelated, and that's what I suspect is happening. So I would not at this point be very concerned about the problems with the vaccine, as I would be much more concerned about the problems with getting COVID-19, especially that these new variants are more infectious. And one of the final things that infection preventionists should be stressing is that all the advisements we've been giving with the initial strain need to be upped for the new strains. We're not sure why they're more infectious. If they can aerosolize more, if the patient is spreading more viruses into the environment, if they survive in the environment longer. So it's almost like going back to base 1. We need to be very, very cautious. We need to up the cleaning, the environmental sanitization. We need to be very careful regarding airflow, air exchanges, air sanitization, and whenever possible, we need to be wearing N95 masks and goggles. And so this needs to be stressed in hospital and high-risk settings. For the public, until this is sorted out, I would suggest relying on either takeout or curbside pickup or delivery as far as getting your food and your staples. That is very important to be doing. Try to wear a well-fitted mask so it's not leaking air around the sides, and make sure that it is double layer. If it is surgical grade, that's good. 3 or more layers, even better if it's a cloth mask. Of course, cloth masks aren't as good as surgical masks. A surgical mask would be preferable. And if you can get an N95, preferably, please get that and wear that if you're going into a high-risk setting. As far as double masking, my beliefs are if you have a very well-fitted mask on as your initial mask, double masking may provide you with additional protection. But if that first mask isn't well fitted and you're leaking air around the sides and you put on an obstruction on the front end, you're just going to leak more air around the sides. And so it might make things worse. So I would be careful on the double masking. I would more stress getting that first mask well fitted and making sure it's of high grade. It's not under your nose. You're not leaking air around the sides. You want to have multiple layers if it's a cloth mask. If you can get a surgical mask, it'll get you more protection, and an N95 better. And of course, that's just partial protection. It'll make things safer, not totally safe. You'd have to wear goggles, gowns, everything else to be even safer than what a mask will give you. And so you can still get the virus, which is why you should socially distance plus wear a mask, not one or the other.
I've asked, I think every expert I've asked has said probably not. The answer is probably not. But I'll ask you anyway. Is it possible that hospitals will mandate that their employees get vaccinated against COVID-19?
Well, probably not. I hate to say that at this point because the vaccine has not been approved by the FDA. It's just been authorized in EUA. As more data gets in, then that may happen. And certainly I think in a setting, let's say a nursing home, if you have a mother that's 90 years old and she's in a nursing home, you would want to have her taken care of by people who were vaccinated. And so I think that at some point it may come to that, especially if we need to get about 85% of this population immune in order to get herd immunity. That's going to be hard to achieve without strong encouragement for people to get vaccinated. Mm-hmm. So we will probably need 70-75% of the people vaccinated, with added to that then those that have natural immunity, to come up with anything close to 85%. And we're going to have to maintain that because, as I said before, this virus is in reservoirs and people around the world, and unfortunately, it also resides in our animals. So we're always probably going to have to get a yearly shot or bi-yearly shot or a shot every other year in order to maintain our immunity to this virus.
And we'll need many more infection preventionists. Hopefully, young people out there watching and watching the pandemic unfold will think about infection prevention as a career. I know APIC is trying to push that as a career path in colleges and universities.
But, yes, definitely. And I mean, let's face it, Frank, 2 years ago, infectious disease and public health was kind of on the back burner, especially public health, epidemiology. It was like, why are you going into that? You know, they were being cut. Health departments were down 50% over a decade with their funding. It was a disaster. And now it's at the pinnacle of importance. Everybody can see how without a well-functioning, well-funded and staffed health department, we're not going to be able to be competitive in the world, because you cannot go through life by keep closing down businesses, by isolating, shutting down your economy. That's not compatible with life. What we need to do is we need to do what was done in South Korea, Taiwan, New Zealand, Australia, to have a robust health department that intervenes, the public follows the advice and interventions, and those countries are largely back to normal right now as we're still in the midst of this pandemic. And even though many states have not shut down their economy, the virus has done it for them. So the virus is really what will decide if the economy opens or closes. And to control the spread of viruses and other dangerous pathogens, we need to have a robust public health care system.
Dr. Kevin Cavanaugh, as always, a fascinating discussion. Thanks for being a member of Infection Control Today's Editorial Advisory Board, and thanks for visiting us here on these podcasts, as always.
Well, thank you very much, Frank. I appreciate it.